Fontan procedure is the final stage in a series of palliative surgeries designed for patients with single ventricle physiology, congenital heart defects, where only one chamber is functionally capable of supporting the systemic circulation, like tricuspid atresia, hypoplastic left heart syndrome, or double inlet left ventricle. The primary goal is to separate the systemic and pulmonary circulations in series, directing deoxygenated systemic venous return directly to the pulmonary arteries without the assistance of a subpulmonary pump. The surgical approach has evolved significantly to improve hemodynamics and reduce long-term complications like atrial arrhythmias. Classical Fontan atriopulmonary connection, initially described in 1971, this involved connecting the right atrium directly to the pulmonary artery. This is largely obsolete today because the resulting massive right atrial dilatation frequently led to refractory atrial arrhythmias and thrombus formation. Lateral tunnel endocardiac circuit. A baffle is created within the right atrium using prosthetic material or atrial wall to channel blood from the inferior vena cava to the pulmonary artery. This keeps the high pressure venous return separate from the rest of the atrium. Extracardiac conduit, the current gold standard. A prosthetic tube, usually Gore-Tex, is used to connect the IVC directly to the pulmonary artery, bypassing the right atrium entirely. Advantages: lower risk of atrial arrhythmias, improved laminar flow, and the ability to perform the procedure without cross-clamping the heart or using cardiopulmonary bypass in some cases. Superior vena cava blood reaches the pulmonary artery through a bidirectional Glenn procedure. The Fontan circulation relies on a passive flow of blood into the lungs driven primarily by central venous pressure rather than a ventricular pulse. Driving force: the pressure gradient between the systemic venous system and the common pulmonary venous atrium is the primary driving force. The fenestration: often a small hole fenestration is left between the Fontan circuit and the atrium. This acts as a pop-off valve, allowing right to left shunting to maintain cardiac output at the cost of mild cyanosis if pulmonary vascular resistance rises acutely. Despite improved survival, the Fontan physiology is inherently limited by chronic venous hypertension and low cardiac output. Hepatic complication: Fontan associated liver disease, chronic congestion leading to cirrhosis, and even the risk of hepatocellular carcinoma. Gastrointestinal: protein losing enteropathy, leakage of serum proteins into the gut due to high venous pressure. Respiratory: plastic bronchitis, formation of cast-like plugs in the airways, highly morbid condition. Hematologic: thromboembolism, sluggish flow and endothelial dysfunction increases stroke and pulmonary embolism risk. Cardiac arrhythmias, particularly intra-atrial re-entrant tachycardia. Follow-up typically involves a multimodality approach: echocardiography to assess single ventricle function, AV valve regurgitation, and Fontan circuit patency. Cardiac MRI, the gold standard for quantifying ventricular volumes and flow, QP by QS. Cardiac catheterization, essential for measuring transpulmonary gradients and pulmonary vascular resistance before and after the procedure.